afternoon. For those of you who don't know me, I'm Nick Timmins. I'm a recovering hack and a senior associate at the Nuffield Trust, and it's my pleasure to introduce the Secretary of State to speak to us. These days, of course, Jeremy Hunt needs no introduction at all. After all, he's been in the job for almost 18 extremely eventful months now. He's appeared on plenty of public platforms. He's written the mandate for NHS England. He's been prominent in all the fallout from the Francis report. And if you're the chief executive of a hospital in this room whose A&E figures have been slipping, he's been on the phone to you. So there's no need for any introduction. So Jeremy, would you like to come and talk to us and take some questions?
Thank you very much indeed. My name is Jeremy Hunt, by the way. Thank you for the brief introduction. And you're right, it has been nearly 18 months. My job is sometimes described as the most difficult job in government. I prefer to think of it as the only job in the cabinet where there's no other MP who's jealous of my job. And I actually believe now, even more strongly than I believed when I was appointed Health Secretary, that it is and will be the biggest privilege of my life to do this job. And I have found it the most extraordinary time. And I really wanted to share with you some reasons why, contrary to what you might read in the media about the NHS after a very, very challenging year, the year of the Francis report, the year when we have had to confront some very hard truths about things that have gone wrong, I am actually very optimistic about the future of the NHS and about the future of healthcare delivery in this country. And I am more optimistic the more people I meet who work in the NHS because of the commitment that I see every day. But let me just give you three reasons, and then we can have some questions after that as to why I am optimistic about the future. And the first actually does relate to what Nick was talking about, which is the Francis report. We've had the Francis report just over a year ago. We had a debate yesterday in the House of Commons about the response to the Francis report. And I have been very humbled and incredibly moved by the response of everyone in the NHS to the Francis report. Not one person that I have spoken to in the last year has said at any stage that this is just about the problems that happened in one hospital in one part of the country. In fact, the opposite. Most people have said to me that the issues raised in Francis are issues that they've encountered in their own organisation, not on the scale of mid-staffs, but they've seen it happening here and there. And what is incredibly impressive has been the total resolve that I think everyone has shown to stamp it out and to say this has no place in our NHS. This wasn't why we joined the NHS. People who want to become healthcare assistants, doctors, nurses, managers in the NHS choose to do so for a reason which is fundamentally connected to human altruism, goodness and humanity. And everything amid staffs that we read about in Francis was a betrayal of that. And I think over the last year, we've seen some huge changes. And if I may say to the Nuffield, actually, some of them happened right here a year ago when I gave a speech on coasting hospitals. And if you'll remember, Jennifer Dixon, when she was working here, did an absolutely seminal report on the issue of whether it was possible to have a rating system for hospitals. I was very keen to do it, but I wanted someone independently to look at it because I was very keen that the new inspection regime that we introduced didn't just focus on identifying failures, but also identified successes so that the hospitals that ended up going to special measures or getting a poor rating would be able to look at the hospitals getting good or outstanding ratings and see the direction of travel and see the ladder that they needed to climb. And I think that's something that's worked very well in education, and I wanted to see if it could work well in health. And that report informed our thinking and had a really important influence on the way the CQC has reformed itself. So if we just look at what's happened in the last year, so in terms of this response to Francis, which I think is way beyond what anyone who was in this room a year ago could have predicted. First of all, the CQC itself has been transformed. It was an organisation that was in deep trouble, that didn't command universal respect, was thought to have an impossible task. And I think under the leadership of David Pryor and David Behan, and with 3 outstanding new chief inspectors, everyone, and I know there are some chief executives in this room who've had some of the CQC inspections. They've done or are doing nearly 40 trusts already in the acute sector, has seen a real change in the way that works. And I think that has been a huge, hugely impressive thing. And as a result of those inspections, we now have 14 hospitals in special measures. They were exactly the hospitals that I was talking about when I gave the speech on coasting hospitals. Hospitals that have, nearly all of them have had problems that date back 5 or 10 years and have got very, very entrenched. And here's something else that I think is incredibly encouraging. When you go to those hospitals, so I was at East Surrey Hospital this morning. Every week I go out somewhere on the NHS front line. And East Surrey Hospital is not in special measures, but they had some very profound problems 3 years ago. You may remember there was a big problem about the way they treated a patient with dementia. Something pretty appalling happened there. And you go there now, and under inspired leadership, there is an energy about that place. They are really turning it around. Basildon Hospital is another one. They are in special measures. And I remember talking to a nurse who worked there for a very long time, and I said, what is the difference now to before? And she said, it's very simple. They listen to us. When we have a problem, we speak out, and the management listen. And the chief executive there goes to the cafe in the hospital every single morning at 8:30, and any member of staff can turn up and raise any concerns they have, and she normally gets about 50 people there every day from across the whole trust, and they feel that anything they say is being listened to. And I think that is an incredibly important lesson about leadership, which we can all reflect on. So what else has happened? Big problems over safe staffing were identified. We've had 3,500 additional nurses recruited across the NHS in just the last year. We have had a big focus on safety. I don't think the NHS has ever thought harder about safety than in the last year. And I want to pay tribute to Norman Williams and David Dalton, who just completed a very important piece of work on where the statutory duty of candour should lie. And they have recommended, and this has been published today, that the statutory duty of candour should apply not just to death or severe harm, but also to moderate harm. And we are, along with changes, and I see we've got the regulators here today as well, and who are cooperating in terms of professional standards. And we will also have a professional duty of candour that will hopefully make it in the professional interests of doctors and nurses to speak out if they see something they're worried about, if there's a near miss, if they see a procedure that hasn't been followed, that will help to make us one of the most open and transparent healthcare systems in the world, very much following the example of the airline industry, which dramatically reduced their accident rate because they understood they needed to make it in the interests of pilots to report incidents rather than to cover them up. And if you think about the cockpit of a plane, that is almost the perfect place for collusion, because there's only 2 people there, and you only got to look at one other person and say, that didn't happen, did it? And they've overcome that in the airline industry with spectacular results in terms of improving their safety levels, and that's the culture we're getting in the NHS as well. So I think the reaction to Francis has been something that we can feel very proud of in the NHS, and that's my first reason for optimism. But of course, the health leaders in this room are dealing with other issues as well, and in particular, wrestling with the challenge of financial sustainability and the ageing population. So my second reason for optimism is the way that I think the service has begun to face up to some of those very difficult challenges. If I just look at the issue of financial sustainability, and I recognise there are some very real challenges here, but I think the national attitude towards reconfiguration has changed. I see that my local chief executive from the Royal Surrey is here, and I remember manning the barricades with him against some plans to close the hospital down at one stage and then at another stage get rid of the A&E when I was a newly elected MP. And there was, I think, an incredible hostility to any organisational changes. I think now, my reading of members of Parliament is that they are in a very different place. They recognise there has to be service change. And I just give you one example, which is the changes in North West London, which have gone through. They were pretty significant changes, 2 A&Es being closed, 2 A&Es being downgraded. And we don't have the unanimous support of every single MP in that area, but actually there has been pretty good support for it, and I think all but one of the local authorities was supportive. And what's the lesson I draw from that? First of all, it was a local project, and secondly, it was led by doctors. And I think both those two things reassured the public that this was going to be the right thing to do. I think the other area where I think the NHS is really beginning to face up to some big changes is to understand that our debate in the NHS over the last 3 or 4 decades has essentially been around hospital services, and in particular the challenge of how to bring down waiting times. And the last government made huge progress, and I pay tribute to them for the progress they made in bringing down waiting times, which was in 1997 the big defining issue of healthcare as far as the public were concerned. I think we now understand, in an era of an ageing population where a quarter of the population have a long-term condition, life expectancy going up by about 2 years every decade, that we have to have a fundamental, radical transformation of out-of-hospital care. And the next big piece of work we need to do to transform care for older people in this country is around out-of-hospital care. And already I think we're seeing some extraordinary innovation happening with the clinical leadership in the CCGs. But I think there is a long, long way to go. And I just sort of point out 2 very significant things that are going to happen in the next couple of months. The first is the introduction of named GPs for the over 75s. That will be, I think, a very welcome return to continuity of care. I would like to see a system where when people are discharged from hospitals, hospital doctors are able to do a handover to an accountable GP that is every bit as detailed and thorough and professional as the handover that happens inside a hospital between shifts, or when someone's moved from one part of the hospital to another part of the hospital. That is going to be a big change, and that programme and how we make that happen is part of a much broader change in general practice, which will, I think, see us move from reactive care in the community to proactive care. And I think is something that I've had excellent discussions with the Royal College of GPs, strong support from the BMA, strong support from 35,000 GPs, and I think there is a real understanding of why we need to make that change. So I think there is a realism about the need for change. And then my final reason for optimism is something that I was talking about in Manchester earlier this week, which is around technology. Because I don't believe that the NHS has really barely begun to scratch the surface of the technology revolution. And so before I came into politics, I set up and ran my own business for 14 years. So we set it up in 1992. If you cast your mind back to how we all felt about the world in 1992, and we were actually in the middle of a recession or just coming out of a recession. People were worried that Japan was going to take over the world, and no one had any idea how the internet was going to completely transform business and completely transform the way we live. And here we are in 2014, 1 in 5 Christmas presents bought online last year. We have half of us now do all our banking online. more than 2/3 of us buy air tickets online. So you've got retail, you've got travel, you've got banking that have been totally transformed by technology. Banking, incidentally, cut a third of their costs, retail banking cut a third of their costs out by essentially making us do all their work for them when we go online to move money between accounts. But that is a very profound change, which has been good for consumers and good for the industry. And in health, we haven't really started to do that. And let me just point to a few things. Now, it's very easy with technology to get carried away about how the world will look in 5 years or 10 years. But let me just give you a few things that are going to happen, not in 5 years or 10 years, but within the next 2 years, to give you an idea of why things are going to change. So electronic health records, hugely important. Everyone in this room knows how important they are in terms of continuity of care, integration agenda between health and social care. By the end of this year, a third of ambulance services will be able to access people's GP records. A third of A&E departments will be able to access GP records. And a third of 111 call centres will be able to access people's GP records, all with their consent, and making sure that we have proper security protections in place. But that will be, and then of course it will roll out beyond that third after this year. But that's a really important, profound change. Second big change is around e-booking and e-consultations. By this time next year, or at least by April next year, 95% of the country will be able to access their own medical records online, free. 95% of the country will be able to book GP appointments online. 95% of the country will be able to order repeat prescriptions online. That will be a very significant change. A third change, again within the next 2 years, is that we will see people with long-term conditions managing their long-term conditions through the use of apps. So particularly for 3.2 million diabetics, this will be an absolutely invaluable way of helping them to get in the driving seat for their own condition. And already NHS England has approved nearly 200 apps, and they're approving more as we go forward. That will be very transformational in terms of linking in an app that might be designed by a developer with a medical record that sits in your GP surgery, and the two being able to talk to each other. And we've signed a kind of single market agreement with the United States so that apps approved for use in the UK will be able to be used in the US, and apps used in the US will be able to be used in the UK, and that's to encourage developers in both countries to start developing these apps. Then there is the care.data change, and I want to pay tribute to the people who've spoken up for care.data, whether in the press or to the NHS community. That is something where the debate we've had is because we decided to do something that hasn't happened before, which is actually to explain a program that's been going on for 25 years and give people an opt-out. That's created a big debate. It's important we have that debate. But the result of that is that we will be able to carry the public with us. And I think when we've gone through this process and with the extra legal protections that we put in place, we will be able to reassure the public, and I think that will lead to huge change as well. And that's before we started talking about the scientific advances that come from sequencing genomes, all of which we are on the cusp of as well. So I think if you take all those things together, we face real challenges in the NHS. We've never had a financial crunch like we've got now. Real terms increases for 30 years, and now essentially the money has remaining at flat real, but it's not increasing anymore, but demand is still going up. So there are very, very serious challenges, real challenges to implement the Francis agenda, real challenges to tackle the challenges of an aging population. But I think what you've got is a set of foundations that we can build on. And I think with the commitment of people in this room and many, many other people, we really have got a chance of making the NHS once again the envy of the world. Thank you very much.
Jeremy, many thanks. I'm sure there'll be loads of questions. If you'd like to put your hands up and ask, I have slight trouble seeing through the lights. Just while you're gathering yourselves, just to come to the financial question, I don't know who you talk to, but I think a lot of people feel that the NHS is finally heading for a financial crisis, either just before or just after the next election. And it's been doing incredibly well so far. I mean, I think if you said in 2010 to most people in this room what would happen after 3 or 4 years of flat real, they'd say it would be in a much worse state than it is. And it's been doing, waiting times have been holding pretty well, the money's not gone crazy, and the various factors in that, not least the public sector pay freeze, which can't go on forever. But there are signs now that the pressures are building. The waiting times are under pressure and increasing numbers of NHS organisations are in deficit. I mean, what's your perception of where it is financially and what do you think needs to be done? Can it get through 14-15, let alone 15-16?
Well, look, I think there are very real challenges. I don't want to pretend for a moment that it's not more financially challenged than that's ever been before. But I think we've had those challenges for the last 3 years. I think we've had a period of where it's been very tough. But we have to embrace innovation. I mean, when I talked about the technology changes, I think that one of the things that we have underestimated is how technology can help cut costs and allow money to be spent on the front line. Things like, I was talking about it at East Surrey Hospital this morning actually, things like reducing the amount of time nurses have to spend filling out forms because you do it through an electronic pass. Those kinds of changes will make a difference. We have to continue to do that because the reason, you talked about waiting times, the reason that waiting times are actually lower than they were at the time of the last election, which is an extraordinary achievement, is because we're doing 800,000 more operations year in, year out than we were 3 years ago, which is a pretty extraordinary thing when you think the budget has basically remained flat across the system, nearly 1 million more operations. We're doing that because we have 15,000 more clinicians in the NHS than we had 3 years ago, and we can only afford those clinicians because we've had to cut away at our back office costs. A lot of the avoidable bureaucracy has been removed, and we have to continue that search. And so I don't want to suggest that's going to be easy, but I would say that it is possible, and I think that technology is perhaps the one area that we could explore much more aggressively in order to make that happen.
Yep, fine. Are there hands raised out there? There's one right there.
Thanks very much. Richard Jones, I'm a cardiologist in Portsmouth, home of the Royal Navy, as you all know, as I think you're an Admiral's son. And as an Admiral's son, you'll know the importance of morale. So the NHS and certainly the front line have taken a real beating and the morale has suffered over the last year, not surprisingly. My question is, what role does the Secretary of State for Health have in being a cheerleader, a generator of morale for the front line? And you've just given us a very positive appraisal, and I wondered if you had any thoughts on how you might generate morale.
Well, first of all, just in terms of the naval analogy that you mentioned as a Portsmouth doctor, one of the things that my father didn't tell me but should have told me is the phrase, "A careless tweet can sink the fleet." I think it's something we all have to remember. But I'm going to stand up because I can't really see people. I have a very important responsibility for morale. And we have come through one of the most difficult periods in the NHS's history where we decided that the way to address serious failings in parts of our NHS was to be honest and transparent. And we lifted up the bonnet on problems that I think everyone knows have been around for a very, very long time. And you are never in that situation going to be able to avoid an impact on morale. But my view is that the way that you achieve a lasting improvement in morale is actually by giving people a sense that you're being honest about the problems and you're confronting them and you're not trying to run away from them. And I hope that's what I've tried to do. And I recognise that I've said some things in the last year that have been very difficult. I actually, in terms of my comments, have always tried to be very supportive of the front line because, from my very first response to Francis, I think that the problem has been that actually doctors and nurses on the front line haven't felt able, because of the system-wide incentives and structures, to do their jobs in the caring, compassionate way that they wanted to do when they joined those professions. But I do think that it is really important to face up to problems. And I think that whilst it will take time for that sense of facing up to problems to filter through to the NHS as a whole, it is very, very visible if you go to some of the hospitals that are put into special measures. Not all of them. Some of them are finding it harder than others. But there is a real improvement in morale in a number of them, where they feel that problems that they've known about as frontline clinicians for a very long time are finally being tackled. And that's something that I think the only real way that you deal with the morale issue.
Jeremy, Neil Bacon from I Want Great Care. Thank you for championing the voice of the patient. Above that, or at least parallel with that of the staff. Yesterday I was with a paramedic team who that morning had picked up an 82-year-old man. He had advanced bladder carcinoma and pneumonia. As he gasped through his nebulizer, he took it off to say, not, is my wife all right, can you get my pyjamas, but to say, no, to demand that the paramedics took him not to the hospital 5 minutes away, but the one 15 minutes away. He wanted to be taken to George's, and he wasn't going to accept being taken anywhere else. So my question is, with the rapid increase in consumerisation of healthcare, an informed and demanding public, is that a good thing for the NHS? Is it a risk or an opportunity? If, perchance, you think it's an opportunity, what's your role in accelerating that benefit?
Well, I think that greater level of consumer awareness is a huge opportunity. And I'm absolutely unreserved in saying so. And by the way, I want to congratulate you and a number of other organisations who've championed innovations to strengthen that sense. And why is that? Because I think there's one thing that we all know: if the NHS is going to be sustainable and if it's going to be financially robust going forward, and that is we need to think more about prevention than about cure. And if we're going to be thinking more about prevention, that means we need people to take more responsibility for their own healthcare and their own lifestyles and the kind of things that could prevent them developing long-term conditions that end up being a significant cost to the health service. And part of that is actually an understanding of where they are going to be able to get the best care within the NHS. And I've always felt that as a constituency MP, one of the big gaps we have in healthcare is, whilst I know exactly how good all the schools are in my constituency, I don't know how good the hospitals are, because we haven't had expert, independent rating system, which we're now going to have, which will, I think, raise that sense of consumer awareness. And the reason for that is not to name and shame people who are underperforming, but to spur improvements in performance. And I think it's important to understand how transparency works. So in July, we became the first country in the world to publish surgery outcome rates for 10 major surgical specialties. And I pay tribute to Professor Norman Williams, who I think is here, who championed that at the Royal College of Surgeons. We've been doing that a very long time in heart surgery. But what that means is that if you're going to have your hip replaced, you can go online and see the success rate of your hip surgeon. Now, most people won't do that, but there's one person who will definitely do that, and that is the hip surgeon. And that's what has happened with heart surgery, and that's why our heart surgery outcomes have changed in the last decade from being some of the worst in Europe to being some of the very best. And I think we can do that across many, many more fields using the power of transparency.
Hands up at the back there.
I absolutely support, Mirav Dover, Chief Officer of Southwark and Lambeth Integrated Care, absolutely support the need for comparative publication of data. I just want to go back to Nigel Edwards' excellent quote about do we treat diabetes, is good diabetes treatment vascular surgery? If we only publish outcomes on hips, should we not also be thinking of this as a system and be publishing outcomes on prevention of needing hip surgery? And how do we do that, and when do we start doing that?
Well, I completely agree with that, and we're at the start of a data revolution, and we'll get better at understanding how to publish that data. But in one way, we already do that, because we are publishing, I think it may already be up, the emergency admissions due to ambulatory conditions by CCG across the country, so that you can actually see which CCGs are better at falls prevention, or which areas are better at falls prevention than others. And the contrast is actually extraordinary. Per 1,000 patients, the worst performing CCG has 186 emergency admissions for falls. The best performing CCG, which happens to be Salford, and I'm getting fed up with Salford getting the top of all these league tables, only has 5 emergency admissions. And so there is a lot of variation, and I think that is... Let me give you a fourth reason for optimism. I mean, look at if you look at public service reform in education or in the police, we don't have the ability to track the performance of every single history teacher in the country and use that as a way of driving improvements in history teaching. We don't have the ability to track the performance of every single detective inspector doing murder investigations throughout the country and compare how good they are. We do have the ability in a limited way to do that in healthcare, which is why we, I think, can blaze a trail, and incidentally, I think the UK can blaze a trail internationally, because I don't think there's anywhere else in the world that is as interested in the possibility of doing this as we are.
Great. There was a hand up near where the microphone was, and can it then go across to that side and then down to the front, please?
Yeah. Stephen Thornton, Deputy Chair at Monitor. Competition in healthcare is a deeply contested issue in this room. There are some people here who believe it is the principal driver for change. There are others who think it's deeply damaging to introduce into healthcare. And I just really wondered where you stand on the issue.
Well, I think that it's very important. The principle of the 2012 Act was that decisions that had previously been incredibly controversial decisions about whether we should use the public sector or the private sector should be taken at a local level by clinicians. And I do think it's important that those clinicians should have the choice and the power to do what they think is right for the patients in their areas. And I do think that it's really important as a system that we are open to innovation, and that innovation can come from outside and can come from non-traditional providers as well as NHS providers, but always with the proviso that whatever we end up with is in the best interests of patients. I think it's perfectly possible to have wholly integrated care that joins up the work that is done by lots of different providers. And some of those providers could be traditional NHS providers, some of them could be voluntary organisations, and some of them could be private sector organisations. And it's a question of working out a system that does that. So I think competition is not an end in itself. I think the end that we seek is the best care for patients. But I think it can have a role in spurring improvements, just as it has in other fields of life. And I think it's really important that we remain open as an NHS to some of the innovation that's happening outside the UK and learn from it, because we want the very best for our NHS patients.
But Jeremy, what you've just described isn't quite what's happening, is it? I mean, the decisions are not entirely being taken locally by commissioners as to whether to use competition or not. A lot of places, they're under pressure to use competition because the lawyers are telling them they have to.
Well, I think there is a bedding down. There are two things that are happening there, which are making it not as smooth as we want it to be. First of all, I think there is a bedding down process with new CCGs that were set up in 2012, and there is sometimes a lack of understanding as to when they need to have a competitive procurement process and when they're just able to commission. And I know that Monitor's making a lot of effort to try and make sure they understand that. I think we also have to get better understanding from the competition authorities as to what their proper role is under the 2003 Enterprise Act, because we are in a period where, as you mentioned earlier, we are all having to cut costs in order to deal with the additional demand that we're getting year in, year out. And so I do think it's very important in when they're looking at whether to intervene in merger decisions between trusts, that they do recognise the backdrop is of a need to avoid unnecessary costs where possible.
Do you think that can be done by persuasion, by explaining to them what their role really ought to be, or does it need a tweak in the law to...
Well, I've had very good after Bournemouth and Poole, I spoke to the competition authorities. I've had an extremely good meeting with Alex Chisholm, who's going to be running the Competition Markets Authority when that comes into office. And I am very confident that they do understand that healthcare is different and that they need to look at the healthcare market in a different way. So, it hasn't been smooth sailing, but I do think that that as the system beds down, we can make sure that the things that are clinically right for patients are allowed to happen and are allowed to happen at pace. Because I think the other issue that a number of trusts raise with me, which I have a great deal of sympathy for, is that it just simply takes much too long. And if you're a company planning a takeover and there's a profit motive at the end of it, then you are quite willing to devote huge resources to putting together proposals and lawyers and all that kind of thing. I don't think trusts have those resources. And I think we have to recognise that they operate in a different way, and we need to have a system which means that they can make those decisions with commissioners and get to a point where they know whether they can go ahead much more quickly.
If you have succeeded in persuading the competition authorities that healthcare is different, that will be a first. Because their response to every sector that comes along and says, we're different, they say, that's what everybody says, and we just apply the same rules. But we'll see. There's a microphone was over there.
Hi, it's the other Jeremy from National Voices. You have taken a very strong position, Secretary of State, championing the interests of patients, particularly in the wake of mid-staffs, the importance of safe, compassionate care, and putting patients first. Which is a phrase used by the department. Your predecessor, if it's not too cheeky to refer to him, used the phrase, no decision about me without me, which put more emphasis on the importance of patients as partners in decisions about their care and about actually the wider system. That's something I've heard you say less about. And I wondered whether you think you have a role in promoting the role of patients, not just as recipients of safe, compassionate care and as consumers, but as partners in decision-making, because there's plenty of evidence that this has positive impacts on quality and indeed on cost. And there are many of us who worry that there is still a culture of paternalism in health. Is there something you can do to overcome that?
I agree with you. I think I think that phrase, nothing about me without me, is a very good phrase. And it's really, I think the big change that we are trying to make, and that I think in 10 years' time we will all say is the biggest transformation in healthcare, is the move away from paternalism to patients being in the driving seat for their own healthcare. And we have to do that on all sorts of levels, not least if we're going to tackle things like obesity and some of the other really important public health issues. I've perhaps used a slightly different and more direct language about putting patients first, because I think we have got parts of the NHS where you've had problems that look not dissimilar to some of the problems in mid-staffs. And, we just need to send a very, very strong signal about patients being the reason we're all doing this and these problems needing to be sorted out. But I think you're absolutely right to say that in the end, this is about patients being the boss and us listening to what they want. And I think as we start to have named GPs for the over 75s, integrated health and social care systems, what you're going to see at the heart of that is the total importance of a patient care plan. And what we're going to see within those care plans is patients themselves being asked as to what they want their care to be. Because I think everyone recognises that unless they have a say, the care plan is unlikely to be realised.
Right, can we have the microphone there, and then can it come down the front, please?
Thanks, Nick. Jeremy, Fiona Godley, editor of the BMJ. We have a breakfast session tomorrow, which I'll take this opportunity to let people know about, at 8 o'clock, which I guess you won't be able to attend, but you'd be very welcome. And the issue we're looking at is 1 year on from the Health and Social Care Act, what's changed? And I wondered if you could give us your thoughts on that, with the implication being, or the specific question being, what's changed that would not have been possible without the Act?
I think the main thing that's changed 1 year on from the health and social... Well, probably, okay, I think there are two things I would point to. First of all, I think clinical leadership at CCGs has been incredibly important, and the trust chief executives that I speak to regularly say to me that they find it easier to deal with a fellow clinician. They find that the language used is the language that they can relate to more easily, and that they find that the kind of strategies that are coming out are better as a result of that clinical leadership. So I think that's a really important change. And I think the second change is that because of the reduction in back office staff, really significant bureaucracies that were in the PCTs and the SHAs, we have been able to invest in many more frontline staff. So we wouldn't have 8,000 more doctors if we hadn't had that health and social care. We wouldn't have 2,000 more nurses if it wasn't for that Health and Social Care Act. And so I think those would be the two things that I would point to as important changes.
While the microphone comes down, can I just follow that up? One thing that's not changed, Jeremy, is that Andrew had this sort of vision of politicians setting the NHS England a mandate and then staying out of the day-to-day involvement of running the service. Do you think that model can ever be made to work?
I think it has. There's probably been more progress in that than you might think.
Some people might say you're one of the most interventionist health secretaries we've ever had.
I would say that there is, I think any health secretary of any government with a democratic mandate has the right to decide on a few priorities that are the areas that they think most need change. So I have picked as the areas that I want to focus on: improving compassionate care, the Francis Agenda, transforming the way we deal with dementia, the technology revolution, and out-of-hospital care as areas that I'm particularly focusing on. And I think any Secretary of State would have those priorities. And I don't think you could do a job like mine without actually deciding a few priorities and focusing on how to change those. But I think that the day-to-day micromanagement is something that happens less. And I think that we have a system that's evolving. It's new, but a system with a mandate where the vast majority of NHS delivery is left to NHS England to deliver as it sees fit in accordance with what's in the mandate. But it will evolve. I don't think it was ever going to be the case that the Secretary of State could step
It's
right
never going
back.
to be as pure as Andrew's model.
I think we are evolving in that way, and I think we also have to recognise that we're a democracy, and people want to hold people like me rightly accountable for, over £100 billion of public money, and so there are always going to be times when the Health Secretary has to involve themselves in operational issues.
Great. You've got the microphone. Sorry. Can you just get it down to the front here? I think we'll have to...
My name's Roland Valori. I'm a physician from Gloucestershire, representing the College of Physicians today. Is it your aspiration to rate clinical services as well as hospitals? And if so, bearing in mind you have 3 chief inspectors, would you be seeing rating of clinical services in those different sectors or across the whole health economy?
Well, this is something I've had very good discussions with the College of Physicians about, and I think ultimately we will develop better ways of doing that. So, for example, the more we can look at outcomes, clinical outcomes, I think that's the thing that matters more than anything else, and that's something that we're starting to do, but there's a long way to go for something like cancer. That's obviously incredibly important. And I think that the Chief Inspector absolutely will look at those as part of the way that they rate hospitals. It's one of their domains, and so they'll certainly be looking at that. So I think it's something that we have to recognise we'll be much better at in 5 years' time than we are now, but it's definitely something that we should be looking at.
All right, we're nearly at the end. One last question. Clive, can you...
As Secretary of State, when I was in the department many years ago, one of my jobs, I think, was to provide early warning to Secretaries of State. Last night I was at a patient participation group in Guildford and Waverley, and we were discussing how Guildford and Waverley CCG was going to deal with the loss of resources or transfer of resources to social services. And we were told by our GP practice that two of the ways were already apparent. One was that thresholds for care had been raised and were being raised, and we could expect more. The particular reference was to cataract surgery. And the other was in cutting back GPs' freedom to refer to London hospitals because they were too expensive. Now, some of us put two and two together and thought, is there not here the makings, if this is anything like typical, of complaints about postcode lotteries on the one hand, and secondly, reductions of choice on the other hand? So my warnings are, you might like to think about that if you're not already.
Well, thank you for the early warning, and as it's my local area, I shall take it very, very seriously indeed. But look, first of all, in terms of postcode lottering, there is always a choice you have to make between, Stalinist top-down or localist free-for-all. And I think we have learnt in the NHS that the Stalinist route actually doesn't work. It creates too much rigidity in the system, and we do need to allow different areas to make different choices and to innovate and to have ownership of those plans. So there will be some differences in the choices that local areas make, but I think that is far more likely to make progress, and we'll have a more flexible and nimble system if we allow that local flexibility than if we choose to do it a different way. But in terms of cutting services because of the Better Care Fund, I would challenge that, and I would challenge any CCG that was taking that approach. I mean, the opportunity of the Better Care Fund is both for the NHS and local authorities to make huge savings because of the avoidance of waste that comes from services that aren't properly joined up. And I think the whole approach of the Better Care Fund is to try and promote that kind of integration. One study I've seen, but I don't know if this is scientific, but one study I've seen says that 80% of those savings accrue to the NHS rather than the social care system, because we're keeping people out of hospitals because they're being better looked after in the community. And so I think the way we've constructed the Better Care Fund is very much to encourage CCGs to do the things that they've always talked about wanting to happen, to use the Better Care Fund to make that happen. So, for example, electronic record sharing has to happen as part of the Better Care Fund. 7-day opening of social services so people get assessments at weekends, be discharged at weekends, has to happen as part of the Better Care Fund. Those are things the NHS has asked for a very, very long time. And I think we should look at the opportunity for cooperation between local authorities and CCGs as a very, very big opportunity to spend money on patient care and not waste it on unnecessary bureaucracy.
Right, and I'm sure there'll be loads of questions around the Better Care Fund, but we're out of time. So on that note, can I just say thank you very much indeed. Can you please thank Jeremy? Thank you for taking so many questions. It's been